morning, everyone. We are placing a Chemoport today for a nice lady who is nice enough to let us live stream her surgery. We're going to do the internal jugular approach for central line placement. And obviously it's going to be under ultrasound guidance. So let's take a look at it. So we have her, this is her head underneath the towel here. Obviously her feet are down there. So this is a right neck that is exposed. So we have our ultrasound probe here. Look back over there. And we have our structures identified. Give me a little pointing stick. So we have the carotid artery. The carotid artery right there, and this is our target, the internal jugular vein. And right now she is in reverse Trendelenburg position, so we're going to put her in T-Berg, Trendelenburg, for a couple reasons. You're going to see that as her head goes down, the vein engorges and swells up to give us a nice, safer target. So this is the jugular vein. So the way we can, if we can't tell the difference between the artery and the vein for some reason, usually you can tell it's a vein because it's much bigger. And then you can also see there's a little muscular wall around the artery here. But if you can't tell, you just press down on the probe and compress the vein because it's a much weaker, lower pressure system, and the wall is not muscular as much as the artery. So the artery doesn't change, the vein collapses, so we know that this is the target. So I'm going to use this micropuncture needle. So we're going to use the ultrasound to identify, we're going to bounce the needle on top of the skin to see where we are. So I'm inserting the needle. See the vein collapse. So I'm going to withdraw, aspirate. There's venous blood there. So now we're going to thread the micro wire. There's no resistance. Needle down. So this is the micro wire. It should be in the vein. We're going to confirm it on the ultrasound. So there's the wire. So now I'm doing a parallel view with the vein. I can see the wire entering the skin on the left tops of the screen. And it's going right into the lumen of the vein. There, that's a nice shot right there. And the artery's right below it. 11 blade. Can you get the table up a little bit? Okay. So now we're going to insert this dilator and sheath over the wire. So I can make a small nick in the skin. That's good. You always want to have control of the wire. So you want to wait till the wire comes out at the end so you have control of it. You don't want to just advance it all the way because you can potentially lose control of the wire and have it get sucked into the IVC or SVC. So I thread it all the way down. I got control of it so it's not going to go anywhere. And then with my dominant hand, I'm going to advance the dilator and sheath over the wire. And the key part is to wiggle the wire back and forth with my other hand so I know that the dilator and sheath are going along the pathway of the wire. If you push everything in, you can forcefully puncture and rupture the back of the vein and go wherever you want. But if you wiggle it back and forth, you're going to go along the pathway of the wire, which we have already confirmed is in the vein based on the ultrasound and aspirating the. So we're going to confirm this. We're going to confirm that we're in the vein by aspirating some blood. There's blood, flushes easily. So now we're going to switch out the micro wire with the 035J wire. It's a little bit bigger, thicker wire. Again, same principles apply. It should go in without any resistance. The anesthesiologist is making sure there's no dysrhythmia. This is the regular size dilator. Same principles apply. Don't lose control of the wire. So here it is. And I like to use a little Raytech to advance to have some friction, moving the wire back and forth. The dilator is going in nicely without any resistance. I'm going to make the skin incision a little bit bigger. So I'm going to remove the dilator. We're going to put the dilator into the tearaway sheath. Insert this as a whole unit. So my one finger is holding pressure on the skin incision site so there's less bleeding. The other two fingers are pinching the wire to have control of it. So we're doing multiple tasks. We're going to control the wire, advance the dilator and sheath while moving this back and forth. So now we are ready with that part. So I like to, without clamping someone's eyeball, I like to pinch up the drape and secure the wire there while we make the port pocket. So come over here. So this is a clavicle, so where you'd like to make incision 2 finger breadths or so below it. Just make a little incision there. Slowly. We're going to ultimately make a pocket big enough to put this port in there. Raytech. So our nice old lady is very cachectic from her condition, so we don't have to make that big of a pocket, or we don't have to make that big of an incision. Have to be very careful because we're going to be right down in her muscle fairly quickly. In a normal size American, there's a thick layer of fat, so normally I would remove a chunk of fat so the port would be more easily accessible. Okay, port and stitch. So these are my anchoring sutures. So, tell us. Come up. We're gonna anchor the port down to the muscle in the three corners. There's a vascular surgeon that I worked with that actually said we don't have to put the sutures in because it takes an extra 2 minutes. But the risk is if you don't, like if it's just free floating around in the pocket, it could sometimes flip over. So then it becomes inaccessible. And then if you want to manipulate the port in the office by trying to flip it over, by pinching the hell out of the patient, they don't like it. So just take a couple minutes to anchor down the port. Oh, that's not it. Stitch. And my staff already knows to pre-flush everything. So when you open up the packet of the port, this is filled with air. So my staff has already, my scrub tech has already accessed the port and flushed it and filled it up with saline. So there's no risk of an air embolus from the port. This is a foreign body and implant, so we like to keep it off the skin as much as possible, even though the skin has been sterilized and prepped. Just want to minimize risk of this getting infected. So now we're going to tunnel. We're going to get this catheter underneath the skin from this incision out through there so we can insert the catheter into the sheath. This little spear stabbing device is what we use to tunnel the catheter. What I like to do is to inject local anesthetic in the pathway of the catheter. It serves two purposes. One is to help with postoperative pain control, and the other is it kind of helps dissect the pathway where the catheter is going to go. I also like to use a little mosquito clamp to open up the target, the exit, a little bit better. So sometimes a little flim clamp. So now so I'm going to use this little spear to tunnel underneath the skin. And then I like to have the tip pointing upwards instead of obviously downwards, so I like to watch where it goes. As long as you're pointing the tip upwards, you're less risk of injuring any of these large external jugular veins or any other structures. So there's still a little flim flam here. So now I've got the tip of the spear. Without removing anything, we're going to pull the catheter through. We're going to trim the tunneling device off. The way I drape the towels, I kind of know where my landmarks are, so the tip of the catheter is going to end up right there. So the skin exit site here is at 28 centimeters. So before I insert the catheter, I like to flush out all the air by squirting out like that. Did I get you? Sorry.
And shower the anesthesia process.
And then we're going to remove a dilator and a wire. So now we just have this one-way valve sheath. So I'm going to put in a little bit extra catheter because we just pull it back. It's not possible. It's not sterile, or it's not safe to advance a wire or a catheter. So I want to put in a little bit extra, give it some slack so you can pull back into the correct position. So this sheath snaps in half. My assistant is going to take one half. I'm going to take the other. Have the biggies just in case, just to feed it through. And then we're going to pull parallel with the floor, because if you pull upwards to tear away the sheath, then you can potentially pull out the catheter. So we're going to go parallel with the floor. Make sure that the entire sheath has been removed. You can tell by the flat edge. So now we're going to go and pull this back until our 28 centimeter mark. About there. We're going to make sure we're in the vein. We're going to aspirate. There's blood, so we're going to flush it. Now we're going to clamp it there and cut it. Now we're going to use the adapter and then get this catheter onto the port to secure it, and then we're almost done. Okay. We're going to float the port down. And then it's not possible to attach the catheter to the port without using your Raytech. And just advance it. And then secure the adapter. So feel a little pop, so everything's secured. So now we're going to tie down our sutures. Can you get her in reverse T-bird?
We're going to put the table down a little bit since we're hitting that floor. And is that okay right there?
My strut sucker is going to hold pressure on the jugular vein. So putting her in reverse Trendelenburg position takes away, drains out some of the blood from the vein, so when we're holding pressure, it's going to coagulate the hole. It's also going to help minimize risk of air embolus for whatever reason. She might get that. She's extremely frail, so I'm just going to give her some more pocket so the skin doesn't get all stretched out. Alright, that's good. So now we're going to make sure the port works because it's in its final position, so we're going to access it with a Huber needle. We're going to aspirate. Blood. We're going to inject, flush it. The proper way of removing the needle is to use your hemostat. Now we're going to inject it, flush it, and lock it with heparin. This is to help prevent blood clots from forming at the tip of the catheter. local. Needle. So this is just a local anesthetic I'm injecting for post-operative pain control. Do it another 10. It's 1/4% bupivacaine. Needle. So I see it kind of puckering up a little bit, so I'm going to try and make it a little bit nicer. Then we're going to use a 3/0 Vicryl. Then we're going to use 3/0 Vicryl in a deep dermal fashion for both incisions. Put some glue on there. Then she'll wake up from anesthesia. She'll go to the recovery room, get an upright chest x-ray to make sure that there's no iatrogenic injury, so no hemo or pneumothorax, and also to make sure the catheter tip is at the right atrial SVC junction. All right, that's it. Thank you.